describe our CT dose. Okay. So the limitation with CTDI volume is actually it doesn't represent the average dose for subject, which is different size. Okay, because now we are using 32 centimeters, so we assuming that all adult patient is 32 centimeter and all pediatric patient is 60 centimeter. Okay, same thickness and same attenuation, which is based on PMMA attenuation. But in reality, we know that in human body, we have a lot of tissues. We have high attenuation tissues such as bone, okay, metal implant if the patient has metal implant, and then we have a low attenuation tissue such as lung, air. So it's actually differ with the individual. Okay, and then we also have a larger patient and smaller patient is also differ in terms of size and thickness. Okay, but as I said just now, it is accepted worldwide, so we are still using CTDI for estimating our CT dose. Okay, but for correction, we have moved to SSDE, which size specific dose estimation that represent correction factors for different individual size, and then we also have that take into account effective diameter, and then we also have water equivalent diameter for SSDE technique that consider different attenuation inside the patient body. Okay, so okay. Okay, next descriptor that usually used in CT is dose length product or DLP. Actually, it is the scan length multiplied by CTDI volume. Okay, scan length is the irradiated length of the patient. Okay, so it is the product of length of the irradiated scan length. Okay, we multiply by the average CTDI. So the unit is milligray centimeter. Okay, it's actually the total dose to phantom or patient along the distance scan. Okay, so for CTDI, it's actually representing the rate of radiation energy on a single slice. Okay, but for dose length product, it's actually the total amount of radiation energy deposited in patient body. Okay, for same protocol, for different, let's say we have two patients using the same protocol, the exposure setting same, you will get the CTDI volume for that patient same. If you are using same KVP, same MS, same pitch, same slice thickness. So the CTDI for both patients will be same. But the difference is only the scan length. Okay, because different patient may have different length, irradiated length. Okay. Okay, is it question or?
No, it's just a background. No
okay,
problem.
all right. Okay, shall I continue?
Yes, please. I'm sorry for your mistake.
All right. Okay, so you may have two patients having same CTDI for the same protocol because you are using the same exposure setting, but may have different DLP because of the different scan length. Okay, so that's the difference between CTDI and dose length product. Okay, so now we go to what is the associated factors that influence our CT dose. Okay, after we scan a patient, okay, the CT scan will produce a dose display sheet. Okay, it is known as post-exam data page. Okay, so the dose report sheet is created upon completion a study. So it will give you how much delivered CTDI volume, DLP for each series, and it will give you also total DLP and the phantom size used to calculate this value. Okay, so this is important, and it is recommended to send the dose report to PACS together with the image. Okay, because it will be the reference for the medical physicists to monitor and manage the dose in radiology. Okay, so it is useful to check CTDI volume after a study is performed to ensure that the output scanner was as expected. And then medical physicists also can compare, okay, the delivered CTDI volume, the local CTDI volume and DLP with the national dose reference level. So you can see either your practice is below or exceed the dose reference level. So it is a good practice and it is recommended. Okay, so I think all of you as a medical physicist is familiar with you. Okay, so different CT scanner give a different display. Okay, this one is for Siemens CT. This one is for GE, and this one is for Toshiba. Okay, but the main dose descriptor should be there. Okay, it is a CTDI volume for each series performed, and then it also give a DLP for each series, and then it give the total DLP, okay, for that examination. Okay, and then it also give you total MAS. Okay, same as GE, it give you CTDI volume, DLP, and also total DLP. Okay, this is very important. Okay, same as Toshiba, it also give you total DLP. Okay, and then CTDI volume for each series of scanning. Okay, and then another important parameter is the phantom size that been used. Okay, is either large size body or small size, which is 60 centimeter. Same as here, it give you the reference phantom use, and also here, okay, body. And then it give you the KVP use, and then the MAS. Okay, for Siemens, it give you the slice thickness, okay, and then exposure time, which is in second. Okay, and then you also get the information of volume, contrast, contrast medium that been used, and then for GE, it gives you the scan range for each series that been used. Okay, and then for Toshiba, it gives you dose, KVP, and also the protocol that been used. Okay. So from the previous data sheet, okay, the factors that affecting CT dose, okay, the main parameters is actually KVP, which is your tube voltage. Okay, so as KVP increase, the dose also increase. Okay, and then tube current output, the MAS. Okay, if you increase the MAS, dose also increase. Okay, the dose is the CTDI. Okay, and then pitch. If you use a lower pitch, the dose will increase. And then beam collimator. If you use narrow beam collimator, the dose will be reduced. and then number of scan phases. Okay, how many phase that you use. Okay, if you use many scan, okay, the dose will increase. And then patient size, if you have small patient and large patient, actually smaller patient, the dose is higher compared to larger patient. Okay, so okay, for first parameter is the KVP. Okay, if you increase the KVP, the CTDI will increase, and then the effective dose will also increase. Okay, for example, here we have two image. Okay, one using 120 and another one using 125 kVp. So the CTDI volume is increased as the kVp increase. Okay, so same as here. Okay, if you reduce the kVp and reduce the MAS, okay, actually it reduce the dose, okay, to about 57%. Okay, and MAS. Okay, so this is an example of chest CT image acquired at different MAS, okay, 240 and 20 MAS, okay, different MAS. And then as you can see, there is a linear reduction in radiation dose as you decrease the MAS. But the problem is the image become noisier. Okay. So but the dose is increased. Okay. So actually it is apa ya kita panggil dia inversely proportional. Okay, if you want a good image quality, you may increase your dose. Okay, but if you want to reduce the dose, then you may lose some of the image quality. So it should be balanced, okay, between image quality and also dose. Okay, but with current technology, actually you can reduce the noise, okay, by keeping the dose low dose, but you can increase the image quality using post-processing technique. Okay. So tube current reduction actually increase noise in mediastinal soft tissue. Okay. All right. And then next parameter that affect CT dose is actually pitch. Okay. When you use lower pitch, okay, you are actually have a more concentrated exposure. Okay, and then more dose were deposited in that area compared to if you use higher pitch. Okay, the concentration of the dose is smaller. Okay, because some part were not covered by the beam. Okay, so this is an example from LIDI study. Okay, so this is using 0.83 pitch. Okay, the dose is 37 milligray. Okay, but if you reduce the pitch using lower pitch, the CTDI increase by 30%. And if you when it changed to higher pitch, which is more than 1, okay, the CTDI is reduced, okay, 45% lower. So when you use lower pitch, you will get higher dose. Okay. Okay, so for pitch equals to 1, it's actually a continuous. Okay. It is describing a continuous beam. Okay. But if pitch more than 1, there will be a gap, okay, between the beam. Okay, and some part were not covered fully by the beam. Okay, in terms of dose, it reduced dose. Okay, but in terms of image quality, it reduced spatial resolution because some part were not covered and you didn't get a signal or data from that part. So what the CT scan do during image reconstruction, for that region, it will be interpolated from the neighboring pixels or neighboring signals. Okay, so some signal will be lost. Okay, so but in terms of those, it reduce. Okay, and then for lower pitch, which is less than 1, is actually defining overlapping beam width. Okay, overlapping beam. Okay, within the scanning. Okay, so if the overlapping, that means some part got double exposure. Okay, maybe double, triple exposure because of the overlapping of the beam. So in terms of dose, the dose will be higher, okay, because more concentrated energy, radiation energy deposited in that same area. But in terms of image quality, it is better because you get more signal of the same area. Okay. All right. Usually for pitch more than 1, we use when we scan a larger area. For example, thorax, abdomen, pelvis protocol (TAP) or chest CAP, chest area, chest, abdomen, pelvic, which involve larger area region. Okay, but for pitch, small pitch, usually it is used to in HRCT, high resolution CT for lung study, or we use it for cardiac imaging. Okay, because in cardiac imaging, it involves moving organ, which is the heart. Okay, so we need more signal. We need better spatial resolution, so we need to use pitch lower than 1. Okay, but if you observe the dose, actually for cardiac imaging, the dose is very high, okay, because of the pitch, okay, because we use pitch lower than 1. Okay, but although we have collimate the beam only for the cardiac region, but the dose is still higher. Okay, so it is one of the major concern, okay, in CT, okay, for the cardiac study. Okay, and then for patient size, okay, the effects of patient size on CT dose, actually when you measure the dose, okay, using the same KVP, okay, actually CT dose is higher. Okay, the measured CT dose is higher in small size phantom compared to body phantoms. Okay, so because it's a smaller size, so the attenuation, the absorbed dose is more concentrated in a smaller region. Okay, so for example here we have 3 different size of phantom. One is 10 cm, 60 centimeter, and 32 centimeter. As you can see, the measured CTDI volume is higher in smaller phantom compared to larger size. Okay. And then the protocol that you use also affects the dose. Okay, for example, if you use 16 and then you use the correct protocol, which is a head protocol using reference size of 60 centimeter, it will give you 37 milligray. But if you use abdomen protocol for 60 centimeter, it will display lower dose. Okay, so it is underestimate. Okay, okay, the dose is supposed to be 37, but it display 80 centimeter. Okay, and then if you use a larger size, okay, same protocol for 32 centimeter, it will display 18 milligray. But if you use a lower protocol, okay, I mean for head, so it will overestimate, okay, the dose, which is 37 milligray. And same as here, okay, it's supposed to be 47 milligray using protocol 10 centimeter, but using 16, it gives you 37. And then for using 32 is actually 18. So using protocol which is larger than the actual size, it will be underestimate. But using larger, smaller protocol, it will actually overestimate the dose. Okay, so this is very important why we use SSDE. Okay, because our patient is not all 32 centimeter and not all 60 centimeter. So by using the SSDE correction, so we actually determine the correct size of the patient, and we divide it by, we multiply by the correction factors for um, the correct effective diameter of the patient. Okay, so this is also one of the area that still I mean sedang apa kiat dilakukan penyelidikan lah. I think Dr. Anam also active in SSDE. So yeah, this is the one of the correct techniques to estimate your patient size. Okay. And then daripada research saya, okay, satu kita buat research on pediatric patient. Okay, sebab pediatric ni kita tahu kanak-kanak sangat kritikal sebab dari saiz yang bayi sehingga ke umur di bawah 18 tahun, perbezaan saiz tu sangat ketara. Okay, so tapi dalam kita punya common practice sekarang, we use 60 centimeter. Okay, so actually daripada research yang kita buat, actually the Asian population, the size is actually smaller than 60 centimeter. So actually what been displayed by CT scanner is actually underestimate. Okay, actually the size is more than the display bila kita buat correction factor. So we know pediatric is the most vulnerable population. So actually we should try to use low dose technique for pediatric. Okay, so SSDE also important to determine the accurate dose for the patient. Okay. Okay, for example here, if you have two patients, okay, one is smaller patient, one is a larger patient. Okay, for reference size, we use body phantoms. Okay, and then we use the same exposure technique for these two patients. And then the emission will display to you 20 milligray, same for both patients. But in reality, it's actually patient dose is higher for the smaller patient. Okay, because although you see both patients having same CTDI volume, but actually the dose is higher in smaller patient. So what need to be done is actually you have to reduce the MAS, okay, to the smaller patient so that the dose will be lower. Okay, the dose will be reduced for this smaller patient. Okay, but actually the patient dose is actually approximately equal. Okay, the value of dose with the size of the patient is actually equal to both patients. Okay. But now, because we have automated modulation technique, automated current modulation, so it's actually the MAS is given based on the size of the patient, okay, from the topogram. So it is one of the technique to adjust the MAS based on the patient size. Okay, but it is based on the topogram of the patient. Okay, but later I will cover that. Okay. All right. So that's uh, all the parameters, but there are other parameters which also affect your CT dose, but I'm not covering in this lecture. But we also have slice thickness. Slice thickness also play important parameters as important parameters to dose. Okay, number of scanning. Okay, and then contrast and non-contrast study also affect your dose. Okay, so of course, contrast will have more phase. It will also increase your dose. Okay, and then we also have a different contrast protocol. One is fixed contrast. Okay, and then another one is bolus tracking. Okay, but in comparison, bolus tracking has more number of scanning phase, and then the dose will be higher for bolus tracking. Okay, so I have covered the LP, and then the last parameters is actually the effective dose. Okay, so actually effective dose indicates the radiation health effects for a population. So how you get the effective dose is by considering the type of radiation and then the factors of organ sensitivity. Okay, because we know different radiation types has different damage or different effects on cells and subject. Okay, alpha beta is the most damaging because it is high energy ionizing radiation, and it also has high LET, linear energy transfer, okay, as compared to gamma and X-ray. So actually alpha beta produce more effects compared to gamma and X-ray. So the factors is higher for alpha beta compared to gamma and X-rays. And then organ sensitivity, the factors are also different for different organ. Okay, because some organ are very radio sensitive, and some organs are not really sensitive to radiation. Okay, it depends on the types of cell. It's either it is dividing cells, okay, active dividing cells, and also matured cell. Okay. Mm. Okay. Effective dose is actually for population. Okay, and it cannot be used to predict individual health effects. Okay, sometimes some people misunderstood the concept of effective dose. Okay, they talk in terms of individual health effects, but actually effective dose should be used for a population. Okay, so for individual, usually we talk about in terms of organ dose or equivalent dose, but effective dose should be presenting a population. Okay, so effective dose is actually a measure of radiation or organ system specific damage in human, and then the unit is sieverts. Okay, so how you obtain the effective dose is by multiplying with the tissue weighting factors. Okay, and DLP. Okay, so you multiply by conversion factors. Okay, and this is based on the ICRP. Okay, we have ICRP 103 is the latest. Okay, and I didn't put it in my slide, but actually you can refer to ICRP 103 for the conversion factor table. Okay, so effective dose is used actually to protect, to set a reference levels for population. Okay, for example, when we want to set a dose limit to radiation worker, we talk in terms of effective diameter. Okay, or guidance for an emergency. So we also use effective dose. Okay, the effective dose can be defined using this equation, or for accurate calculation, we usually use dose calculation software. Okay, this is some example of dose calculation software. Some are free, some are licensed. Okay, you need to apply for license, and some are commercially available and you need to buy it. Okay, so I think City Expo is free, but the limitation is the model that it use. Okay, it is more geometrical and it's not really accurate. But for NCICT and then for City Expo, sorry, City Virtual Dose, it is more accurate. Okay, because it representing the actual anatomical structure of the human. Okay, so this is some of the dose calculation. Okay, maybe some of you have gone this through this software. Okay, so you need to in the software you need to include some parameters, okay, from the city examination, and then it will automatically calculate for you organ dose and also effective dose. Okay, in my center we utilize GE, okay, GE dose watch. Okay, so actually we are very honored. So we actually receive a demo trial from GE Healthcare Asian. Okay, we received it in 2018. Okay, actually they proposed me for 1 year, but now until now we are still getting the free trial. Okay, so actually it's good because we connect with our CT scanner, and then we send all the dose report and images to the dose watch, and it helps us to calculate the effective dose and organ dose. Okay, okay, so this is the software, the platform of the software. Okay, it use a Duke model. Okay, and then we can also calculate dose to fetus. Okay, for example, in this, it gives us dose to fetus. And then it can also give us the organ dose. Okay, for each area. Okay, and then sometimes the mapping of the organ region is not correct, so we can do a manual correction. Okay, and then it will correct the organ dose to you, and then it will give you the effective dose for that individual, and then we can collect for all the population and we get the mean. Okay, so this is the dose watch. Another interesting features in dose watch is it can also calculate for you SSDE, and then you can also get miscentering from your examination. Okay, so it is very good. And then we also get an offer from Ready Matrix. Okay, but that time because I have accept the GE invitation, so I have to uh, exclude the Ready Matrix. But it's also good because it gives you calculation. Okay. So this is one of the my publication. We share our experience with commercial dose wash. Okay. Another thing is it can track your dose from CT examination, and then it can give you information of the higher dose. Okay. So you can, as a medical physicist, you can investigate why that particular exam produce higher dose. Is it because of the pitch? Is it because of the number of scanning? So it is very helpful for medical physicists. Okay. Okay. So for CT scanning, okay, so the effective dose, actually we use the effective dose to representing the yearly radiation exposure. Okay, for example, here is an example in Australia by Arpansa. Okay, so actually the highest exposure in Australia is due to medical exposure. Okay, and then this is from US. Okay, from NCRP. Okay, for average annual radiation dose in US. Okay, so as you can see, medical exposure and background exposure is almost the same. Okay, recently. And from medical, the highest portion of dose is actually due to CT. Okay, and then interventional fluoroscopy, although it produce higher dose same as CT, but the frequency is small. Okay, and then you have nuclear medicine, it's about 12%. Okay, so actually CT produce a larger, almost a larger portion of the medical exposure. Okay. That's mean the frequency is more. Okay. And then because it also tomographic and it's also produce higher dose. Okay, so it should be one of the major concern among the practitioner. Okay. Okay, when we compare the effective dose of received from CT, okay, compared to general X-ray, actually for chest X-ray, the effective dose is about 0.02. But for chest CT, it is 3 millisievert. Okay, it is equivalent to 150 times of chest X-ray. Okay, and then for head, if you compare head MRI, okay, because it's non-ionizing, so no radiation dose. Okay, for X-ray of head is equivalent to 0.4 days of flying. But if we compare CT scan, it's about 30.4 days of lying. It's about approximately 1 year of background radiation, exposure to one background radiation. Okay, but for X-ray it's only 11 days. Okay, and then for low back region, okay, if you use ultrasound or MRI, is a 0 because it is non-ionizing radiation. Okay, but for X-ray, it's about 213 days of background radiation exposure. Okay, but using CT, it's about 511 days of background radiation exposure. So actually, CT scan deliver higher radiation dose than the standard X-ray. Okay, so this is one of the major concern. Okay, because CT scan deliver higher dose, okay, to patient. Okay. All right. Do we need to have a break in between, or we can continue?
Actually, the presentation is 7 minutes more. And after that, we will have a discussion session until 10:30.
All right. Okay. So I will proceed. Okay. Okay. So this is the last part of my talk, which is the strategies to reduce CT dose in in our practice. Okay, the big challenge in CT imaging is to balance between image quality, which is the benefits, okay, the diagnosis quality, and also to reduce as much as possible the risk, okay, which is the radiation dose. Okay, so this is where the radiation protection principle play its rules. Okay, so justification where uh, the radiation exposure should not be performed unless it demonstrates significant benefit. So benefit should exceed the risk. Okay, so in dose management in CT, for clinical team, there must be a radiologist, radiographer, and medical physicist that work together as a team. Okay, so physicist should be the person that consult the radiologist and radiographer. Okay, should bring the awareness that the risk should be always keep as low as possible. Okay, using Alara concept. Okay, so there are some. These are some strategies for dose reduction. Okay, so one is adjustment based on patient size, as I mentioned before. Okay, and then adapt to clinical indication. See what is the diagnosis quality based on the clinical indication. Okay, for example, you have head protocol, head CT protocol, but for different indication. Okay, for example, for brain study, for fracture, if you want to see the fracture trauma. Okay, so different clinical indication actually employ different protocol, and then use automatic pitch adoption. Okay, and then this is also important, limiting the scan length and the scan phase, and this is also has been used, okay, which is automatic exposure control, or AEC. Okay, the most important thing is how you position your patient, because miscentering actually affect the dose to patient. Okay, so it is important to center the patient right in the center of the gantry. Okay, if the mispositioning, then the dose will increase by 11 to 15%. And this is a very common error. Okay, this is from our dose watch. As you can see, it gives us how many shift of the patient from the actual isocenter. So here is actually about 3.8 centimeter shift. okay, at X. Okay, so it is also important to make sure that the patient positioning is accurate. Okay, and then how many scanning also important. Okay, because by reducing number of faces, okay, you actually can reduce the CT dose to patient. Okay, so okay, this is important. Okay, especially for contrast study. Okay, so you have to limit the number of scanning. Okay, because it will affect your total DLP and also CTDI volume. Okay, so there are some technology advancement that have been employed, that has been invented for dose reduction. Okay, for example, MDCT or MSCT, multi-slice CT. And then we also have dual energy CT, where you get a low and high KVP raw data, okay, acquisition. Okay, helical and spiral. I believe most of the CT scanner now using a spiral CT. And then instead of using conventional FBP, now they are introducing iterative image reconstruction. And nowadays, they are moving to deep learning reconstruction, which can also reduce dose. And then the automatic exposure control, also one of the technique to reduce the dose. Okay, so this is MSCT. Okay, so using multi-slice CT is actually you can improve your image quality because the detected element is very small, so the spatial resolution is increased. Okay, and then because you get multiple slice per scanning, so you actually can reduce scanning time and you can reduce radiation exposure, and in the same time you can reduce the dose. Okay, so okay, you can reduce the dose and you can reduce the exposure time. Okay, and then the next is tube current modulation, one of the techniques now. Okay, so the tube current modulation is done based on different patient thickness. Okay, based on the tube angles. Okay, so it use angular tube current modulation. Okay, so for thin part, it will use low tube current, and then for thicker part, it will use higher tube current. So the modulation is based on the thickness of the patient. And then it will also do the modulation based on the attenuation, okay, of the different structure inside the body. Okay, we know the thorax region consists of air. Okay, it is low attenuation tissue because we have lung, so it will give you lower MAS. But for shoulder, because it consists of high attenuation, okay, we have bone, so it will give higher MAS. Okay, so the modulation is depending the attenuation along the scan length. Okay, so this is the combination of longitudinal and angular tube current modulation. So this is one of the technique to reduce the dose to patient. Okay, and then iterative reconstruction. Okay, so in this study, it compare between HIR and MIR. As you can see, using HIR, it can reduce dose about 20%. But using MIR, it also reduce dose, but the image quality is better. Okay, so iterative can also reduce dose to patient. Okay, in recent study, they use a deep learning reconstruction or DLR. Okay, using DLR actually noise and spatial resolution is preserved, and then it also demonstrate 50%, 52% of dose reduction compared to iterative reconstruction. So deep learning reconstruction is also one of the recent technologies or recent invention that been done to reduce the dose. Okay, so that's all from me. Before I end my lecture, I would like to promote our incoming event, which is International Seminar on Medical Physics, which is organized by Malaysian Association of Medical Physics together with USM and also Al-Buhari. It will be held in hybrid mode. It can be physical or virtual. Okay, for further information, you can go to this website. Okay, and then this is the themes for the events. Okay, with that, I would like to thank everyone, and I'm apologize for any shortcoming from me. Okay, so terima kasih dan harap dapat berjumpa lagi insyaAllah di masa hadapan. Okay.
Terima kasih. Thank you very much, Dr. Nur, for the presentation. These were very condensed presentations and also deep and about it's also give us refreshing information about the CT scan and also how the CT works and also CTDI and the development of CT scan also it's already presented. And I believe many of us wants to know about the development of CT dosimetry and also the challenge in CT dosimetry, because as you already mentioned in your presentations, that CTDI volume is not the patient dose. So there's some some differences between the informations that is presented in the console, in the CT console, and the actual informations or the actual dose that is received by the patients. I think it's still a challenge for us to really understand and to really get the grip how to evaluate or how to calculate the real patient dose in this case or in this manner. And we already have several questions here in the chat box, and we also invite to all audience to ask questions. The question can be in Bahasa and also can be in English. Don't worry. I think we can also make discussions in Bahasa if Dr. Nois don't mind.
Yes, can. Boleh.
Boleh saja ya.
Yeah.
But due to the the manner of the conference, I still doing the presentation, the communication in English. But first we can first we have the questions from Mr. Asep Taufik. So Mr. Asep, are you still here? Maybe you can ask directly to Dr. Noor of your questions.
Yes, so, I'm here.
Yeah, please you can have a discussion in Indonesia. We don't mind.
Yes.
In Indonesia, Mr.
Dr.
Noor.
Yeah.
Thank you very much for your presentation. I speak in Indonesia.
Yeah.
Dr. Noor, itu kan tadi Dr. Noor menyampaikan tentang menjelaskan tentang automatic tube current modulation ya dok ya. Ibu, ini yang ingin saya tanyakan pada automatic tube current modulation itu kan berarti kan secara otomatis akan berubah nilai MA-nya arusnya ketika objeknya itu mengalami perubahan begitu. Nah, jika
Okay, and then Mr. Asep, we lost your sound. or we can make summarize from the chat. So what is the impact of the current tube and the noise value with the and noise when
MAS
using
value?
yeah, by using ATCM? So means that when we are not using ATCM and with using ATCM, so what is the impact on the, I think maybe on the noise value perhaps? Or do you have any comments on this, Dr. Moon?
Okay, actually for tube current modulation, it has a default I mean intensity value, okay, of X-ray photons received by the detector. Okay, so when the detector receive the I mean the default intensity of the X-ray, it will stop the MAS, okay, automatically. Okay, so in terms of noise, it affects because the MAS will affect the number of photon detected by the detector. So if we use a less MAS value, lower value, so the noise will also reduce. Noise will increase. Okay, because noise will increase as number of photon detected reduce. Am I answering your question?
Yeah, but maybe you also can elaborate. So in terms of the image quality, which one is better in producing better image? The one that using the automatic current modulations or without using it?
Okay,
in your experience.
actually using AEC is better, okay, compared to manual, because the CT scanner will estimate the MAS based on the thickness and attenuation of the patient. Okay, because we do the topogram, and then from the topogram, it will estimate the thickness of the patient. Okay, and then the attenuation, okay, based on the region. Okay, so it is better because using manual, it will give the same effective MAS
throughout the whole body.
Yeah, throughout the whole body. Okay, some part may be noisier, some part less noise. Yeah, compared to using automatic AEC.
Yeah. Okay, I see. So it means that the image quality won't be homogeneous when we are using the manual, I guess.
Yeah.
Compared to using the ATCM. Okay, I think that's it short out the question perhaps, I think. And now we go to the next questions from Mr. Farid Porianto. Mr. Farid, do you want to ask the questions by yourself?
Pakai bahasa Indonesia aja, Pak.
Yes, please, don't worry. No problem.
Oke, terima kasih Dr. Nur. Saya ingin bertanya, apakah ada batas spesifik untuk berat badan bagi penggunaan CTDI yang lebih tinggi atau yang lebih rendah gitu? Terima kasih.
Okay, the limitations of the weight body of patients ini.
Weight.
Yeah.
Weight.
Berat badan maksudnya, Bu.
Specific weight, so berat badan.
Okay, sebenarnya sekarang dia belum implement weight. Actually, international have done the dose referral level based on the weight. But for SSDE now, we are using only effective diameter and also water equivalent diameter, DW. So for weight, actually, the BMI, okay? It is more accurate actually because it take into account the thickness of the body, okay, from the wig, and then it also take the length of the patient from patient height so that you get the BMI. Dari segi CTDI, actually it is not implemented yet Okay, even in Malaysia kita belum buat those referral level based on BMI. Tapi for international, memang it is recommended to use BMI. Okay, to estimate SSDE lah, SSDE based on
Yeah. But do we have a direct calculations for that if you are using the BMI?
using BMI direct
Yeah.
calculation. I think no,
Is it-
not yet.
Not yet. Okay.
Yeah.
Oh, then it will be a new topic of research then.
Yeah.
Can be a chance. It's interesting because I think based on the BMI, we can see the influence of the density of the body density with the absorbed dose because depending with the sometimes I think the diameter is also reflecting the density, but sometimes some people have like different
Height.
tissue proportions in their body. So for with the same diameter for some patients perhaps with the same diameter, then the patients can be obese or can be very like athlete.
Yeah.
Different tissue types or tissue thickness.
Lagi satu saya rasa lah limitation dengan current practice bila you are in a busy hospital.
Yeah.
Jarang-jarang sebenarnya kita ambil information weight and height tu.
Okay.
Even for example in my practice sekarang in Malaysia, we actually revising our national DRL. So we actually aim to include the BMI. But it's not the apa ya kita cakap practice biasa dalam examination. So bila you have a lot of patient daily.
Oh, sorry. Miss Nur, can you unmute because I'm accidentally mute your.
Okay, so kita tak sempat ambil patient punya berat dan juga BMI tu lah. Okay, I'm not sure in Indonesia what is the practice. Are you taking a week for each patient yang datang before CT examination?
I don't think it's a common practice still.
That's the limitation.
Yeah.
So we also actually promoting hospital to get the weight so that we can get the information.
But what do you think the influence of these informations in we are also incorporated the factor to those calculation? Will it like for example, will it influence until like 15% or 20% increase or decrease if we are including the factor, or is it just a minor adding of the dose? Means that if we are not including the BMI, then the dose value will be like make the deviations like in 5%. So it won't be that much deeper. What do you think about it?
Actually, it may affect because as I mentioned just now, patient size affect our dose. Okay, and then we know we are Asian population. Asian population actually is smaller than the Western. Okay, and from my research actually, for adult also, for Malaysian population we are smaller than 32 centimeter. Okay, from my research is in between 26, 24 like that is the average size of adult in Malaysia.
Yeah.
So actually, it's not 5%, it's more than 5% underestimation of the dose. Okay, so we don't want to underestimate the dose. Okay, because of the reference size, which is larger than our population.
Yeah, I think it's interesting because different populations have their different people size. Therefore, we need to adapt with the regions. I mean, so the machine needs to adapt, and the calculations of the machine need to adapt to the patient's regions in that region. Yeah, I think it's interesting for further studies. And then goes to the next questions. Yeah, I hope my audio is clear enough now. And is it clear enough for you, Dr. Noor, my sound?
Yes, yes.
Okay, so I hope the problem is localized, not to all audience. We go to the next questions from Mr. Arich. So Mr. Arich is here. Maybe Mr. Arich can ask the questions directly.
Okay, sir. Thank you very much.
Yeah.
So I have one question. So in this slides, you show the interface for dose watch. So how is it actually work to measure the organ dose? In the GUI, it shows the city localizer or topogram image. So is it obtaining the dose from that image or the actual image itself? Thank you.
You mean the technique, how the dose watch, the protocol or the technique of the dose watch to give the organ dose, is it, Mr. Arich?
Yes, exactly.
Okay, yeah. Perhaps Dr. Noor had some insight about how the dose watch work, perhaps?
Okay,
Yes.
in the dose watch, actually, we have to send all the DICOM images.
Yeah.
Okay, so it will get the information from the metadata of the DICOM image, all the exposure settings. So it will estimate based on the exposure setting that we give. Okay, and then it also can give us the information of organ dose based on the each scanning phase that we use. Give it can give different organ dose for different scanning phase. For example, we have a non-contrast, it gives the organ dose, and then contrast phase, it give a different organ dose. And then just now you see the city localizer. Okay, it's actually to just to mapping the region. Okay, to accurately mapping the region because in chest we have different organ, and then in abdomen we have different organs, so we have to accurately map. If not, it will give inaccurate organ dose. Okay, so how it measure is actually depending on the information from the exposure setting that we use, the scanning phase that we employ, and also the localizer is to map the region. Okay, untuk kita petakan apa bahagian-bahagian yang berkenaan lah. Contohnya macam chest, abdomen dan thorax. Okay, dia juga boleh bagi kita SSDE. Dia akan kirakan untuk kita diameter pesakit, lepas tu dia teruskan klik dengan SSDE. So you can compare the display dose and also the actual SSDE based on the individual dose. That's the interesting features of dose watch.
Okay. Mr. Aris, is it answering your question?
Oh yeah. So the localizer image is just to
Mapping.
mapping. Oh yeah. Oh yeah. Okay. It's very clear, sir. Thank you.
Thank you very much, Mr. Aris. And go to the next question again now. It's from Miss Yarmita, asking about what is the difference between single energy CT with the dual energy CT. Is it the dosimetry procedure similar or not?
Okay, for dual energy, actually you get two acquisition at different energy. One is at low energy, and another one is high energy. I'm sorry because I didn't cover that part.
Okay.
But actually there are three techniques to get the dual energy. One is by using dual X-ray tube. One X-ray tube for low energy, one X-ray tube for high energy, and then you have two detectors for different X-ray tube. Okay, that one is employed by Siemens. Okay, but at my center, although I use Siemens for dual energy, but because of the limited budget, so we only have one X-ray tube, but it can do dual energy. What it do is first it scan with low energy, okay, go into gantry, and then it will come out from the gantry with high KVP, and then you will get two image, two raw data image. One is low energy, another one is high energy, and then we can apa ya kita panggil, kita akan ni dia merge dia. So you dapat dual energy acquisition. Because we know the attenuation is different at low energy and high energy. So the principle of different attenuation is used in dual energy. Okay, for example, at my place, what we do is dual energy is used to differentiate stone in the kidney. Okay, because we know different composition of stone, we need different treatment. Okay, we can determine either the stone is uric acid or calcium. So using dual energy, it can give you the information. Okay, different composition of stone, kidney stones.
Okay, and what about the dosimetry of the dual energy? Is it similar, the procedure, the way we evaluate the CTDI perhaps? Medicine?
Actually, when we read the commercial, what we say, commercial punya,
or the advertisement you mean of the machine?
advertisement ke, memang mostly said it can reduce. Okay, I try to compare one of my student doing comparison of single CT and dual energy in KUB. Actually, when you use high KVP, you actually reduce the MAS. Okay, and then you can get different energy acquisition, but at the same scanning. So as compared to single acquisition, you have to double the acquisition. So the dose will be higher compared to dual energy. So that's why in dual energy, actually the dose will be lower, because when you use higher energy, you actually reduce the MAS. Okay, and then dual acquisition at the same exposure also can reduce dose to patient.
Okay. Is it takes a longer time to do the scan with the dual energy?
Longer time?
Yeah, is it takes longer time with dual energy compared to the single energy?
The dual energy is shorter.
Oh, shorter. Okay.
Yeah, because you but it depends on the machine. Okay, because we have three techniques. One is sandwich detector, dual X-ray tube, and another one is a fast KVP switching. Fast KVP switching use one X-ray tube, but it switch between low and high KVP. Actually, it's shorter exposure time because it get the acquisition on the same scanning, so that's why it's shorter. As compared to single, you have to take one acquisition
the whole
lower.
360 rotations goes to the next locations and then do the same round. Okay, that makes sense, because that makes the dose reduced. Okay, Miss Yanurita, is it clear enough for you?
It's clear. Thank you very much.
Okay.
Dr. Dordiana and Pak Panji.
Thank you. To Surabaya, Miss Yanurita.
Thank you.
ITS from Surabaya.
Very impressive talk. Thank you very much.
Okay, now
makasih Pak.
Okay, sama-sama. Now we go to it's the last question, because we only have 4 minutes left. This is from Mr. Adi Wasono. Mr. Adi, are you here? Perhaps you want to ask the questions directly.
Okay, Dr. Dur. My question is that my machine is using a fast KV switching in dual energy. So, but I don't have any CTDA phantom yet. So I am curious about the CTDA profile if we using in dual energy mode. is it a different profile with the single energy? Because my machine is using a fast QV switching. In my, I thinking is switching between QV so fast. So is it the profile will be different?
For I have never have experience in measuring CTDI volume in dual energy mode, because usually in our annual QA we still employ the single energy. Okay, we take the standard, okay, 120 kVp and 200 mS, because it's I mean the standard protocol for measuring CTDI. So I never try using dual energy mode. So I'm not sure about the profile looks.
But do you have any predictions on that, perhaps, if we are doing it? Or we have any comments on that?
I'm not sure.
Okay.
I have to check on it.
Okay.
But
yeah,
because in the practice,
Mhm.
we don't have to take a dual energy, because we use the same KVP. Only the machine will estimate for us either it is using dual energy or single energy, because we give the reference value as recommended by manufacturer. We use 120 kVp and 200 mAs for our annual CTDI measurement. But I think for research, yeah, maybe we can try to see the dose profile for dual energy.
Yeah.
Yeah,
Okay.
it's a new
Yeah. Because Mr. Adi is working at the hospital, perhaps. I think at the Boromius Hospital. Is it correct, Mr. Adi? In Bandung?
Okay.
Yes, sir. Yes, sir.
Maybe in the future we can collaborations also together with Dr. Anam. I believe Mr. Adi is the students of Mr. Anam, I guess.
Okay. So for
following-
CTDI, actually, I know it's expensive to buy. In my center, I fabricate my own CTDI, because I want to see different size of phantoms, a CTDI phantom. So I fabricate, because I know it is very expensive.
Yeah.
Okay.
Yeah.
So
it's a
maybe you
challenge.
can try. Yeah, you can try to
Yeah.
design and fabricate by your own using PMMA, but with standard size.
Okay. Now I think it's only 1 minute left. It's very interesting talk, and also very fruitful discussions, Dr. Nur. Thank you very much for allowing us to receive your very, very generous presentations.
Okay,
And
thank
we
you.
do hope that you won't get bored to give us another lecture in the future, perhaps.
Inshallah,
And
inshallah.
also, maybe when the situation is getting better, maybe we can invite you to go to come to Semarang, and then have
Inshallah,
another
inshallah.
discussions, and also
Yeah,
collaborations with
yeah.
Dr. Anam, and
Yeah,
also
yeah.
with all of us. And thank you very much for having us here. And we hope that the discussions, today's discussion, will give many beneficial knowledge for all the audience.
Yeah.
And we hope that we can meet again in the future with another topic and another presenter. Thank you very much. And we return the time to the MC Dr. Jatmiko to close the sessions. Thank you. Wassalamualaikum warahmatullahi wabarakatuh.
Terima kasih semuanya.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Dr. Panji, as my moderator. Thank you very much for talk from Dr. Diana. The talk is very interesting, and there are more 300 in Zoom, and also attending by YouTube. And finally, I will share on behalf Physics Department Universitas Diponegoro. Want to give some certificate for you. Please receive the certificate, and this file will be sent by email.
Okay, thank you.
Thank you. Yeah.
Terima
Thank you
kasih
very
semua.
much. Yeah. I hope
Yeah.
next time we can see direct. Yeah.
Ya, insyaallah,
Yeah.
insyaallah.
Okay. Thank you for Dr. Nurdiana and all
Okay,
participants
terima kasih.
attending. Okay.
Ya.
I think it's enough. I close this general lecture. Thank you very much.
Oke, terima
Oke, thank you
kasih
very
Terima
much.
kasih.
semua.
Terima kasih.
Terima kasih Dr. Nur, sampai jumpa lagi.
Ya, ya,
Ya,
insyaallah.
Oke.
Terima kasih.
insyaallah.
Oke,
Terima
sama-sama.
kasih Dr. Nur.
Yuk.
Ya, ya.
Assalamualaikum warahmatullahi wabarakatuh.
Terima kasih kerana menjemput saya. Minta maaf ya apa-apa yang kurang.
Ya, sangat sangat berlebih Dr. Nur, sangat berlebih.
Saya berlebih.
Oke, pamit. Saya izin pamit.
Pamit.
Oke, terima kasih. Waalaikumsalam.
Sama. Oke, bye-bye.
Bye. Tutup gimana? Tutup gimana?
Depan nih, di belakang.